Okay, let's start the proceedings since we have started the recording now. And hello and welcome to 27th PMA webinar on behalf of PMA President Professor Salma Kundi. I am Dr. Qazi Wasiq from PMA to moderate today as Professor Mulazim Hussain is busy in a seminar. This series of webinar is being organized by Pakistan Medical Association as an academic activity in collaboration with Pakistan Association of Pathologists, Azad Jammu and Kashmir Medical College, and Women Medical College, Abbottabad. Today we have a very important topic of modifiable risk factors in carcinoma breast. And today we'll have two speakers. One is Dr. Maryam Zubair. She'll be talking about the carcinoma breast. And then we'll have another presentation. Hope she'll also join Dr. Frzana Sabir. And today's panelist is Professor Ziad Kiani. Professor Ziad Kiani is Head of Surgery, Abbas Institute of Medical Sciences, Azad Jammu and Kashmir Medical College, Muzaffarabad. So let's start with the presentation by Dr. Maryam Zubair. Dr. Maryam Zubair is Assistant Professor of Gynae and Obs, Azad Jammu and Kashmir Medical College. She is Supervisor of FCPS, MCPS training, and currently focal person for Carcinoma Breast Awareness Campaign in Azad Jammu and Kashmir. I'll request Dr. Qaisar Sajjad, Secretary General, Pakistan Medical Association, to recite a few verses from Holy Quran. Dr. Qaisar Sajjad, please do that.
Okay, thank you very much, Dr. Qazi. Bismillahir Rahmanir Rahim. Qul huwallahu ahad, Allahu samad, lam yalid walam yulad walam yakul lahu kufuwan ahad. Sadaqallahu al-azim.
Jazakallah. Thank you, Dr. Qaisar Sajjad. And now I'll request Dr. Maryam Zubair to start her presentation on carcinoma breast. It's over to you, Dr. Maryam.
Thank you very much, sir. I thank you and PMA and our principal, Professor Mulazim Hussain Bukhari, to provide me the opportunity to have this talk on a very important subject today. Bismillahir Rahmanir Rahim. So, breast cancer awareness. The topic for today's talk is modifiable risk factors for breast cancer. The first question arises in our mind that what do we know about breast cancer? Breast cancer is the second leading cause of death in women next to lung cancer. 1 out of 9 women in the US will develop breast cancer in their lifetime. In Pakistan, 90,000 new cases per year are reported. Out of them, 40,000 die. Breast cancer is a cancer that primarily affects women, but 1% of cases may occur in men. Everyone is at risk of developing cancer. As per statistics, 7 women die from breast cancer every day in Australia. 1 in 8 women will be diagnosed with breast cancer in their lifetime. The question arises, why to focus on awareness? Because it is dangerously high incidence in Pakistan, and this disease is curable. It can be detected early if routine breast examinations are practiced. The most important thing is life after the treatment of breast cancer is the same as it was before and is worth living. control of this disease will have significant financial implications in a developing country like ours. Regarding breast cancer, 15 to 20% of breast cancers are familiar. Only 5 to 10% have hereditary cause, which includes BRCA1 and BRCA2 mutations. 70 to 80% of breast cancers are sporadic. Now, what do we need to know about breast cancer? Chance of getting or dying from breast cancer increases with age. Most of the cancers are not inherited. So there are many things that if we know, we can reduce the risk of breast cancer by diagnosing it earlier. 70% of breast cancers occur in women who have no identifiable risk factors. 24 women in every 1 lakh are diagnosed every year with CA breast. Question comes, what causes breast cancer? So there are certain risk factors that can lead to development of breast cancer. They may be genetic, they may be environmental. We broadly classify these risk factors into modifiable and non-modifiable. The non-modifiable breast cancer risks are gender, age, genetic risk factors, family history, personal history, race, menstrual cycle, that is early menarche or late menopause, and estrogen. The risk factors that are associated with our lifestyle and that we call modifiable are oral contraceptive use, women that are not having children, hormone replacement therapy, not lactating, use of alcohol and smoking, high BMI, high fat diet, and physical inactivity. So we were talking about the risk factors of breast cancer, which are genetic and environmental, and we broadly classify them into non-modifiable and modifiable risk factors. So as I have already told that the non-modifiable risk factors are those that cannot be prevented, that include gender, age, genetic risk factors, family history, personal history, race, menstrual cycle, that is early menarche or late menopause, and estrogen. And modifiable risk factors that can be modified by changing our lifestyle include oral contraceptive use, women who do not have children, women using hormone replacement therapy, non-lactating women, use of alcohol and smoking, high BMI, high fat diet, and physical inactivity. Certain other risk factors are radiation to chest or face before the age of 30, certain breast changes that are benign may increase the risk of CA breast, race, ethnicity, use of HRT, and dense breast tissues having more granular tissue, low vitamin D levels, light exposure at night, diethylstilbestol exposure in utero, exposure to chemicals that are in cosmetics, in foods, in gardens, in plastic, in water, in sunscreens, and in grilled or smoked food. One thing is very alarming, that is the risk of breast cancer is more in career women, in working women. Career women have 70% higher risk of developing breast cancer than housewives or women in lower status form. Main top causes for increased risk in career women are not lactating, delayed pregnancies, stress at workplace, air pollution, and lack of sleep. When we talk about risk factors associated with reproductive health, pregnancy is the foremost and first factor that we will be talking about. Patients who do not have children or who have less number of children are at increased risk of developing breast carcinoma. Pregnancy protects against breast cancer by reducing the number of menstrual cycles and exposure to endogenous hormones. These patients with high BMI, patients having high cholesterol diet and sedentary lifestyle habits are at increased risk of developing CA breast. Use of oral contraceptive pills is known risk factors which can cause CA breast. The association of use of OCPs with breast cancer is dose and duration dependent, and it is also dependent on age. Hormone replacement therapy given in peri and postmenopausal women has association with development of carcinoma breast. Women Health Initiative and Million Women Study were two trials that were conducted to see the association of carcinoma breast and hormone replacement therapy. Many women were recruited in these trials to see this association. Fortunately, the trials were stopped earlier due to deaths of many women secondary to cardiovascular events and stroke, but the association was determined by the time period they have recruited the women, and these studies conclude that there is a strong association with hormone replacement therapy and development of carcinoma breast. And they say that combined estrogen progesterone preparations are the are the main culprit for developing CA breast. Alone is also found associated with this risk, while vaginal preparations do not increase the risk. So, what are the shields that can protect against development of CA breast? Late menarche and earlier menopause increases the risk because of decreased exposure to estrogen. Having children at an earlier age, before the age of 30, also reduces the risk of carcinoma breast. Physically active women have lower risk of developing this deadly cancer. And there is a role of preemptive mastectomy, especially in the patients who are found to have hereditary risk factors and who are BRCA gene positive. There is a role of preemptive mastectomy to prevent the disease. So as we all know, prevention is always better than cure. All the risk factors that can cause CA breast, including obesity, nulliparity, non-lactating use of alcohol and cigarette smokes, use of HRT and OCPs, and having not having exercises. These are all the women who are at increased risk of developing carcinoma breast. So if we can control these modifiable risk factors, we can control on this development of carcinoma breast. So we always start with lifestyle modification that includes reduction in weight through healthy diet and exercise. They say it has proven through studies that a brisk walk of at least 1.25 to 2.5 hours per week reduces the risk of cancer significantly. And if we increase this duration up to 10 hours per week, the risk becomes minimal. Smoking and use of alcohol and avoiding stress are also the keys to prevent this development of CA breast. While we talk about risk of oral contraceptive pill and development of carcinoma breast, we have to be very, very careful in giving the advice and in promoting the reducing the risk by giving alternate options of contraception, so that we should keep the birth spacing as well, because there are studies who have proven that maternal mortality or deaths of mothers in reproductive age due to childbirth is double the mortality associated with carcinoma breast. So being a gynecologist, I feel this is my responsibility that when I talk about the contraception, OCP's association with risk of development of carcinoma breast, we should all keep in mind that we should offer alternate contraception to the women of reproductive age. These alternate contraceptive methods can include non-hormonal contraceptives, copper IUCDs, barrier methods, natural methods, and also the oral contraceptive pills with low dose estrogen can can also be offered. Intrauterine devices containing levonorgestrel have also shown to have an association with development of carcinoma breast. Pregnancy and lactation are protective, as I already said. So, number of pregnancies, if there are more, there is less risk of development of carcinoma breast. For lactation, duration and frequency of breastfeeding counts. Increased duration and increased frequency of breastfeeding and breastfeeding a child for at least 2 years are important factors to reduce the risk of CA breast. During pregnancy, antenatal visits give us an excellent opportunity for health education, teaching the women about self-breast examination and screening for breast cancer in patients who have got high risk for development of this cancer. For hormone replacement therapy, we have to weigh benefits and risks before starting hormone replacement therapy to a woman who needs it. And if we are starting HRT, we have to follow up the patients regularly. There are alternate methods that can be offered to patients for different symptoms, like healthy diet rich in vitamins and minerals, plenty of fluid intake, exercise. And for vasomotor symptoms, we can give the patient selective sortilin reuptake inhibitors, which have got an excellent result. Vaginal preparations can be given for urogenital symptoms. Supplementation of multivitamins and vitamin D are very important. And there are herbal products like primrose oil, soya, and black seed uh, that can help the women coping with this aging problem in menopause. So there are certain signs and symptoms of CA breast that we need to teach women when we offer them education and screening. Commonly lump or thickening in the breast, often painless discharge, bleeding, change in size and contour of breast, redness and pitting of the skin around the breast, pudgy orange skin, change in color and appearance of areola. These are all signs and symptoms that can warrant a woman for seeking a medical advice. So again, enlargement, asymmetries, retraction of nipples, eczema-like condition, dimpling, nodule, ulceration, pudgy orange, and Sister Joseph nodule and umbilicus. They're all the signs that we can see in patients with complaints of any breast change. As I've said, that awareness regarding breast cancer is very important because it is a disease which is curable. So there is surgery, there is radiation therapy, there is chemotherapy, and targeted hormone therapy that can cause that we can offer the patient who develop breast cancer. Early diagnosis is important because if you diagnose the cancer at an earlier stage, there is increased 5-year and 10-year survival. Like you can see in the slide, at stage 0, 10-year survival is 90%, with at stage 4 comes to only 2%. So diagnosing is important. Why 10-year survival? Mortality in CF breast include late detection, poor compliance with treatment, concurrent diseases, poor access to care, and the certain barriers to care. So early detection is the key to save lives. Early detection is possible through self-breast examination, clinical breast examination, mammography, ultrasound, MRI, and biopsy. So Dr. Frzana would be talking more about these modalities, that how we can make patients aware about self-examination and how we do clinical examination and rest of the investigations to diagnose the breast cancer earlier. I would be skipping it. Once one thing I want to focus on, that we should always tell the women the time period when they should do self-test examination. In menstruating women, 5 to 7 days after beginning of the periods. In menopausal women, on the same date each month. Patients who have irregular periods, same date each month. Pregnant women, same date each month. Patients do not practice self-breast examination because of fear, embarrassment, being young, lack of knowledge, and being too busy or forgetful. Now, what can we do to reduce the risk of breast cancer? Checklist is, at the age of 20 to 39, patient should do monthly self-breast examination, yearly breast examination by doctors, and mammogram every 2 to 3 years. At the age of 40 plus, patient should do monthly self-breast examination, every 6 monthly clinical breast examination, and yearly mammogram. So detection of breast cancer uh, by self or clinical breast examination is possible about 2.5 centimeter lump size. And when we go on further investigations like mammogram, ultrasound, MRI, or biopsy, even smaller size lumps can detect CA breast. We should be working on creating awareness by inviting support group meetings, trainings and conferences, free screening clinics, walks for women, community events, breast cancer awareness events, and online continuing education. So I will conclude with this picture of Angelina Jolie, who had a prophylactic mastectomy because she had two first-degree relatives in her family who were diagnosed with breast and ovarian cancer. And she says that I want my grandchildren to see me, so to protect myself from breast cancer due to strong family history and hereditary predisposition, she had prophylactic mastectomy. October is the month which is celebrated to create awareness against breast cancer. Thank you very much.
Okay, thank you very much, Dr. Maryam. For the next talk, I'll request Dr. Frzana Sabir. Dr. Frzana Sabir is working as surgical specialist at Abbas Institute of Medical Sciences and Associate Professor of Surgery at Azad Jammu and Kashmir Medical College, Muzaffarabad, having 19 years of experience in breast. Thank you, Dr. Frzana Sabir. Please go ahead.
Good, thank you so much, sir, providing me this opportunity to discuss this much important topic that I was anxiously waiting to talk about, this hot issue of the time, that was emerging health issue of the carcinoma of breast, affecting the poor female community and their families all over the world. And it needs kind consideration of whole of the health department to play their role at all the levels. So coming to today's topic of discussion, that is the modifiable risk factors of carcinoma breast. And I will like to share the screen.
In the meantime, I would like to welcome Professor Majid Chaudhary, who is teacher of teachers. He is also. Professor Chaudhary, would you like to say something?
I think, we have grown old having a look at the disasters of cancer of the breast. I remember joining King Edward Medical College way back more than 4 decades ago, and was horrified after coming back from England to see the incidence of carcinoma of breast, which to date remains exactly the same which it was in 1979 when I joined as a young assistant professor. And then, I was in Frzana Medical College as principal and head of department of surgery. And there, would you believe that we used to do 6 mastectomies a day, every unit. And then I I tried to develop a well-women breast clinic in King Edward, but couldn't do it because of certain social reasons. But then when I became principal, I actually started with the just under everything under one roof in Frzana Medical College. And well women clinic, and we used to pick up 2.8% of cases of cancer of the breast in walking-in women. And I tell you, over the last 43 years, what I have observed, we have been able to do nothing, honestly. Be it educated class, be it, forget about people coming from the villages, because unfortunately, they don't have, they have access to, but they don't want to see doctors, particularly male doctors. And as you know, in Pakistan, I think now 70% girls are there, and your basic health units are lying vacant. So if at all they would like to, and so, to be quite honest, nobody would like to send their daughters to rural areas in this day.
Yes, sir.
So I think the problem remains the same.
Sir, let's have Dr. Frzana now.
That's
Thank you
only hope.
very much, Professor Chaudhary, for your very valuable comments. And
Okay.
I think Dr. Frzana Sabir is
Okay.
now ready.
Okay, we'll continue.
Dr.
Can
Frzana
we
Sabir.
now? So today our topic of discussion is modifiable risk factors of the carcinoma breast. And we will come to know about these risk factors, which are the contributing and which are the protective. Similarly, we will differentiate between the modifiable and the non-modifiable risk factors. Why we are saying them modifiable? Similarly, what is the importance of these modifiable risk factors? We will come to know the pathophysiology of these risk factors and how can they be modified, and who can play the role in the prevention of carcinoma breast and modification of the risk factors. Similarly, we will decide some of the action plans. The carcinoma breast, it is the most frequent diagnosed cancer in women. And worldwide, the lifetime risk is 13%. So having 1 in 9 chance to develop carcinoma breast. And when we see this carcinoma breast in Pakistan, it has highest incidence rate among the Asian countries. While the chance of mortality with carcinoma breast is 2.6%, that means 1 in 39 chance of death with carcinoma breast. So these are the figures of the Pakistan. And to improve survival and reduce the mortality with this carcinoma breast, we need an extensive awareness program about the genetics and environmental factors. And that helps to make informed decisions, especially in the prevention and the early detection and treatment. So today we will focus on the prevention of the carcinoma breast. The risk factors that are contributing in the causation of the carcinoma breast, they are divided into non-modifiable risk factors and modifiable risk factors. The non-modifiable risk factors are those factors that cannot be by any mean or any change. For example, age. Getting older is the risk factor that cannot be changed. And with the increase in the age, there is the increased risk of the carcinoma breast. Similarly, Gender is another important non-modifiable risk factor that it is the disease of the females. Only 1% of the carcinoma breast that occur in the male. Rest of the patients are females. Similarly, family history and genetic predisposition is the element that is the risk factor. Early menarche, late menopause, is increased exposure to the hormones, so they cause carcinoma breast. Nulliparity is important contributing risk factor, and radiation to the chest. Whenever the patient has a disease that requires radiation to the chest in the childhood, that may lead to the development of other cancers later on, and the carcinoma breast is one of them. Night shift workers, they are at the increased risk of developing carcinoma breast, like nurses, doctors, police officers, factory workers. They work in the night, they are exposed to light, and this light later on affects and it may result in the causation of carcinoma breast. These are the non-modifiable risk factors. When we talk about the modifiable risk factors, on the other hand, these are the risk factors that can be modified, that can be changed by the simple measures, by changing the lifestyle. So our focus is to identify these risk factors and work on it so that we can help these poor ladies to prevent the disease. So all the modifiable risk factors, when they are identified and we can change them, we can be hopeful to prevent the carcinoma breast. Among these modifiable risk factors, like age at first childbirth, early the age at the first childbirth, that is protective, but when the woman is more than 30 years of age at her first childbirth, that is a contributing risk factor in the development of carcinoma breast. Similarly, number of completed pregnancies. So the increased number of completed pregnancies is the protective risk factor. On the other hand, oral contraceptive pills, hormone replacement therapy means increased exposure to the hormones that are the contributing factors. When we talk about breastfeeding, it should be encouraged because the breastfeeding for the longer time is the protective risk factor, and its absence or the short duration of breastfeeding, they may result in the development of the carcinoma of breast. So when we talk about the sedentary lifestyle, it is also the risk factor because it results in the overweightage and obesity. It reduces the physical activity. So when the basal metabolic index is high, it is a contributing factor. Similarly, low physical activity is the contributing factor. Unhealthy diets, they contain increased high-fat diet and they decrease the vegetables. So again, they are the contributing risk factors. Alcohol intake and smoking, again, they can be changed in the life with the change of the lifestyle, and they are the modifiable risk factors. Radiation to the chest is a modifiable risk factor in case when a disease is having other choices of the treatment other than radiation. So should be considered other than radiations whenever there is possibility. Nulliparity is a strong modifiable risk factor. That means with the marriage, there is increased chances of having full-term pregnancies. So that is the protective risk factor. So nulliparity should be discouraged. So by recognizing these modifiable risk factors, we want to see what is the modifiable risk factor. So we say these are the risk factors that can be modified in the population through behavioral changes. And one can take measures to change them and can find ways to avoid health problems. Usually, these risk factors, modifiable risk factors, they demand change of lifestyle. And why they are important? They are important because they have the role in the prevention of the development of disease. So here we are talking about carcinoma breast. So these modifiable risk factors of the carcinoma breast, they have role in the prevention if they can be changed, if they can be modified. And decreasing these risks of the breast cancer through prevention of modifiable risk factors, this is the task that requires the participation of all the society, especially the health professionals who are responsible for the female population. When we talk about health professionals, we see the primary health workers like lady health workers, midwives, medical officers, either working in the rural area or the urban area, the surgeons, the gynecologists. These are all the population that can affect their community by the awareness program. So primary health workers, they have a very vital role in the identification of these modifiable risk factors and working on them and preparing the community, the female, to change the lifestyle so that the rate of this breast cancer can be lessened. And how these risk factors, they affect the breast to cause carcinoma breast. So we can see that the prolonged exposure to estrogen that feeds breast cells to grow. So breast cells, they need estrogen to grow, and whenever the females, they are exposed to increased estrogen levels, prolonged estrogen levels, they are at the risk of development of carcinoma breast. Among these risk factors, we identify early menarche, late menopause, oral contraceptive pills, similarly, hormone replacement therapy. So all of these are hormone dependent, and these hormones may lead to development of carcinoma breast. When we see pregnancy, we say the full-term pregnancy. Full-term pregnancy pushes breast cells into final phase of maturation. So the chances of getting mutation is less, and it is the protective risk factor. Breastfeeding is the protective risk factor when it is longer duration and frequent, and it is so because through the breastfeeding there is less exposure to the hormones which are responsible for the development of carcinoma breast. When we talk about the obesity, what happens in the obesity? There is increased adipose tissue. This increased adipose tissue causes increased conversion of androgens to estrogens. Again, the level of estrogens are high, especially in the postmenopausal age when the androgens are in increased level. So the conversion of androgens to estrogen provides increased level of estrogen in case of obesity, resulting in development of carcinoma breast. What alcohol does? Alcohol results in formation of carcinogenic end products. It affects digestion of vitamins adversely, and it also increases estrogen. So when the alcohol is taken in increased amount and frequently, it may result in the development of carcinoma breast. And what's about night shift work? Night shift work causes increased exposure to the light of the women, and it causes inhibition of melatonin synthesis. Again, increased estrogen levels. When the level of melatonin is decreased, it causes increased synthesis of estrogen, and increased exposure to this hormone may result in development of carcinoma breast in night shift workers. And mostly these night shift workers, they are nurses, they are doctors. So the health professionals themselves are at the increased risk of development of carcinoma breast. By knowing the modifiable risk factors, having the knowledge of these risk factors, there are some recommendations through which we can control this disease to some extent. And it based upon community education, either individual and group. So the community education can address the physical activity like diet, obesity, weight, tobacco, alcohol. So there is a need to tell the community, to inform the community, and to aware them about the physical activity, that about 30 to 60 minutes per day physical activity is the minimum. That means 3 to 4 hours per week physical activity is required, low to high intensity, that maintains healthy weight, it lowers the hormone levels, it increases metabolism and immune system. So it is then protective risk factor. Healthy diet with the increase in the intake of vegetables, fruits, fibers, and decrease in alcohol, red meat, animal fat, it will be protective. So it will affect prevention of the development of carcinoma breast. So there is a need to reduce the obesity and excess weight. It can be addressed. The community awareness is important to maintain the normal weights. Also, reduce tobacco and alcohol consumption reduces the hormones, and to lower the carcinogenic end products, it is important to talk about these risk factors. What are the actions when we come across non-modifiable risk factors that cannot be changed? For example, family history, a very important risk factor in which there is usually the mutation of BRCA1 and BRCA2 genes. And these women, they need early genetic testing, and they have to come across different breast cancer screening schedule. That means the more younger age than general population, so they have to avail these screening schedules earlier in the age. And when detected, prophylactic mastectomy can be offered them. Now, education is a very important factor in the awareness of the females to prevent the carcinoma breast development. And how this education can help? It can help in the prevention, in the treatment. And when we talk about prevention of the breast cancer, we say that the primary healthcare is very important, and the primary healthcare can play a very important role in the promotion and prevention of the breast care to increase the awareness about the risk factors and to modify them and how to modify them. So the primary healthcare workers, they can play exclusively a very important role. And they can provide awareness about the early detection and referral of suspected cases to the specialist. So seeking early treatment will improve the results. This aspect of education of the community through the primary healthcare needs training of the primary healthcare professionals that should be included in the health policy. As many of the countries of the world, they are practicing it, they train their primary healthcare professionals and they have their role in the prevention of development of carcinoma breast. So our recommendations are to train these primary health workers, send them in the community and educate the community for the awareness for the prevention of the disease. So prevention of modifiable risk factors by changing the lifestyle through education is the mainstay. It needs to be incorporated in the different levels of the life and emphasized of general education. That means it should be incorporated in early stages of the life. That means it should be the part of curriculum and the parents should be educated. So the parents can be educated and the children through the curriculum, they can be encouraged for the breastfeeding, having increased number of children, early ages, marriages and early age at first pregnancy and encouraging the parity. Through the curriculum, we can emphasize on diet, exercise, weight, maintaining the normal basal metabolic index. We can emphasize on the advantages of physical activity, risk of alcohol and smoking can be shared with them. And health providers at all the levels of the care can aware women via the counseling, written material, flyers, displaying posters and banners. So it is an easy job when we train our health providers, send them to the community and counsel the females. Here the specialists have their own important role in the prevention of carcinoma of the breast. That along with offering the treatment to the carcinoma breast, they can play their role in the prevention. The specialists, they identify modifiable risk factors and address them, and they spread their message into the community through the community education or awareness. And this awareness emphasizes through the seminars, arranging the workshops, breast clinics, through the outpatient clinics, disseminating the material, information containing flyers through the media, and displaying posters and banners inside the hospitals and in the community. Also, when we come across non-modifiable risk factor, where these risk factors cannot be modified, cannot be changed, here the early detection of the disease is important. To find the disease in early stages for early treatment, for better outcome. Again, this is the awareness program. This is the education of the community that can play important role for the early detection. And especially the awareness in the schools, colleges, and universities to the girls about the breast self-examination and breast screening. And breast self-examination should be taught, and report to physician in case of any change should be encouraged. Breast screening is provided through the clinical examination, mammography and ultrasound in young women, and MRI in high-risk women. Now, the awareness of women about modifiable risk factors of carcinoma breast is all that is needed in the prevention of the carcinoma of the breast. It means कि खवातीन को awareness चाहिए कि उनको क्या इंफॉर्मेशन होनी चाहिए कि ये कैंसर कैसे हो सकता है और वो कैंसर जैसे मुजी और जानलेवा बीमारी से बचाव की क्या तदाबीर कर सकती हैं। तो इसके लिए पहले तो उन्हें रिस्क फैक्टर्स से आगाही होनी चाहिए कि कौन कौन से रिस्क फैक्टर्स उनको ये बीमारी होने में मदद करते हैं और कौन से ऐसे रिस्क फैक्टर्स हैं जो कि इस बीमारी से बचाव में मददगार साबित हो सकते हैं। तो यहाँ उनसे बात की जा सकती है, उनको अवेयर किया जा सकता है चेंज ऑफ लाइफस्टाइल के लिए, इसका कॉन्सेप्ट दिया जा सकता है। सेडेंटरी लाइफस्टाइल पे उनको अवेयर किया जा सकता है कि होता क्या सेडेंटरी लाइफस्टाइल, उसके क्या मुज़र असरात हैं और इससे कैसे बचाव किया जा सकता है। सिमिलरली दे कैन बी टीच अबाउट के फिजिकल एक्टिविटी क्या है, वॉक को प्रमोट किया जा सकता है, चहलकदमी वर्जिश एक्टिविटी को प्रमोट करना है और ये किस तरह से अफेक्ट करेंगी, कैसे प्रिवेंशन करेंगी ब्रेस्ट कैंसर को, तो इस पर उनको आगाही देने की जरूरत है। बेसल मेटाबॉलिक इंडेक्स क्या होता है ये उनसे डिस्कस करना चाहिए और ये प्राइमरी हेल्थ वर्कर्स बहुत अच्छी तरह से कर सकते हैं। हाइट के मुताबिक वेट कितना होना चाहिए, इसको कैसे नापा जा सकता है, कैसे तोला जा सकता है, इसके चार्ट मुहैया किए जाएं और ज़रूरत से ज़्यादा वजन को डिस्करेज किया जाए। सिमिलरली डाइटरी एडवाइस दे सकते हैं, हेल्दी डाइट क्या होता है इसके बारे में आगाही दी जाए, चर्बी और गोश्त के नुकसानात बताए जाएं, सब्जी और फ्रूट के फवायद पर बात की जाए। इसी तरह से ये हेल्थ वर्कर्स रिप्रोडक्शन को पर आगाही दे सकते हैं कि भाई रिप्रोडक्शन में लाइक ब्रेस्ट फीडिंग है तो इसको प्रमोट किया जाए और बताया जाए कि कम से कम 1 से 2 इयर्स तक, 1 से 2 साल के लिए ब्रेस्ट फीडिंग को कंटिन्यू किया जाए। ये बताया जाए कि पहले बच्चे की पैदाइश पे 30 साल से कम उम्र में फायदा है और ये फायदेमंद साबित हो सकता है कैंसर के अगेंस्ट। ज्यादा बच्चों की पैदाइश भी फायदेमंद हो सकती है। बच्चों की पैदाइश फायदेमंद है तो अर्ली मैरिजेस को इनकरेज किया जाए। सिमिलरली बीइंग सिंगल को डिस्करेज करने की जरूरत है क्योंकि नली पैरिटी सामने आती है जबकि नली पैरिटी इज अ स्ट्रॉन्ग रिस्क फैक्टर और बच्चे ना होने की जो नुकसानात हैं कैंसर पे वो उनसे डिस्कस किए जाएं और आगाही दी जाए। इसी तरह सिगरेट पीने के नुकसानात, अल्कोहल के नुकसानात पे आगाही दी जा सकती है। So in today's conversation, we were able to recognize risk factor of carcinoma breast and the importance of modifiable risk factors and their pathophysiology in the development of carcinoma breast. And we have recommended the change in the lifestyle and how we have discussed here. Similarly, we have discussed the role of primary care and primary healthcare providers in the awareness program of prevention of carcinoma breast by controlling modifiable risk factors. And we have discussed the role of specialists और ये सब करने से यकीनन हम प्रिवेंशन ऑफ कार्सिनोमा ब्रेस्ट कर सकेंगे और किसी हद तक इसके रेट को फॉल कर सकेंगे। Thank you so much.
Thank you, Dr. Frzana, for your excellent talk. And now we have our panelist, Professor Ziad Kiani. Professor Ziad Kiani is Head of Surgery, Abbas Institute of Medical Sciences, Azad Jammu and Kashmir Medical College, Muzaffarabad. We would like to have his comments on the subject. Professor Ziad Kiani.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Thank you, Pakistan Medical Association, the Association of Pathologists, Women Medical College, and AJK Medical College for this webinar on such an important healthcare issue. Also, I'm thankful to Dr. Maryam and Dr. Frzana for their presentations and how they have enlightened us on the disease. As we all know that breast cancer ranks first in all the cancers diagnosed in women worldwide, and it's one of the leading cause of death. A lot has been done in last 20 to 25 years. Still, a lot also needs to be done. But in last 20 to 25 years, there has been an increase in understanding of multi-step carcinogenesis and the leading role of genetic change in the diagnosis, treatment, and prevention of the breast cancer. So a lot has been already talked about modifiable and non-modifiable risk factors. I also want to share an important study, that is, it was a meta-analysis on study of risk factors in Southeast Asia. And in that study, in that meta-analysis, in modifiable risk factors, parity was the highest. It has the highest odds ratio, that was 1.85. And it was followed by overweight, obesity, that is raised by body mass index. And then it was also followed by oral contraceptives, the use of oral contraceptives. While in case of non-form modifiable risk factors, it was the family history of breast cancer, which was 2.5. So what we need to improve on, the presenters, they have already told us the roadmap, how can we do it. Different organizations are working here. But for what we have done till now, I tend to agree with what Professor Majid Chaudhary has said. And we were not able to contribute significantly to decrease the risk or to increase the healthcare seeking behavior of these females. And still the healthcare seeking behavior is not up to the standard. So we tend to find these women and the families having misery with cancer and the problems they're facing afterwards. So, what we actually need is, we need to have education, we need to have frequent webinars or seminars or community orientations, and we need counseling, yes, about healthcare seeking behavior to improve that, and in which, in this aspect, the primary healthcare system of LHVs and then posting of female doctors in different basic health units and rural health centers, it will improve. Of course, we can talk about eating habits, avoiding of contraceptives or use of alternative contraceptive techniques. And then comes the screening programs, and Dr. Maryam and Dr. Frzana, they've already elaborated them very well. So I agree with them. So thank you very much, and for taking my views and for asking me to be here. And if any questions about the presentations or the topic, I'm here to satisfy it, or I'm here, whatever, how can I contribute on it? Thank you.
Thank you, Professor Ziad Kiani. And now the floor is open for the question and answers. For the question, please raise your hand, or you can unmute and ask directly. We have.
Can I make a comment?
Please go ahead, Professor Majid. Yes, we'll have your comment, and then we have some questions. Okay.
Yeah, I think, as I said earlier, we have been dealing with this disease for a very long time, and unfortunately, in this country, things haven't changed a bit. For example, can I narrate a couple of stories with apology to the ladies? For example, I remember seeing a patient, a lady with a cancer of the breast from KPK. And the man asked, and he said, how much is it going to cost? It was a couple of decades ago. I said, oh, it used to be very nominal fee in those days. And he said, let me think. He went out and came back and he said, Professor Saab, इसमें तो हम एक नई बीवी खरीद सकता है. That's, I'm talking about the mindset of people. And then there was a poet from the city of Kusur. I operated upon his wife and I said, look, there should be no pregnancy again. And about a year and a half later, they came to me with an inflammatory carcinoma of the other breast. And pardon me saying that, but in this country, I think we have maltreated women. And you know, abhi tak, I tell you, I'm a practicing surgeon in the city of Lahore for the last 40 years, that early breast cancer is very, very rare. Now, a couple of things that the lady was talking about is about alcoholism, and you know, that's not uncommon in big cities like Lahore or Karachi or Islamabad. Alcoholism in female is not an uncommon phenomenon at all. And I think that may be one of the contributory factors. But unfortunately, I think there are such social taboos that people don't present early, even amongst the educated class. No matter, we have been crying hoarse, self-examination and whatnot, and on social media. But I think the ultimate result at this stage, I'm involved in Cancer Care Hospital of Lahore, which we have kind of built. It's a 350-bedded hospital where everything is free, including there are 3 linear accelerators. Can you hear me?
Oh, yes. Carry on. Yes, we can hear you.
There are 3 linear accelerators there, and even chemotherapy is even provided free to a lot of people. But unfortunately, I think the load of cancer of breast remains exactly the same. I was talking to one of the professors in Fatima Jinnah Medical College, where I was telling we used to do about 6 mastectomies a day. My son works there. He is assistant professor of surgery, and he says that nothing has changed. It's still the same in the city of Lahore. Imagine, where presumably people are educated, but the dilemma of cancer of breast honestly hasn't changed a bit. What I have witnessed over the last 4 decades, unfortunately.
Okay, thank you, Professor Majid. Then there's a question from Dr. Mosana in the chat box. This is screening in far areas where approach of patient to hospital is very difficult on the part of patient. Proposed strategies over awareness of breast screening. I'll request our panelist, Professor Ziad Kayani, to answer this question very briefly. Professor Ziad.
Yes, thank you very much. It is a very pertinent question. Of course, it's the place which we are living in, that is AJK. It is 80-20 rural-urban ratio. So healthcare seeking behavior is already very poor, and so we need to train the primary healthcare workers, that is the LHVs and LHWs who are working in the community, and of course they need to be treated for early screening programs, to implement early screening programs.
Please go ahead.
I think gene testing at the moment is very expensive at the moment in this country, and gene therapy is even more expensive in this country. Our problem is really not the prophylaxis at the moment. I think the disease is absolutely rampant in our country. We need to do some intervention at the level of the government to educate people. One of our biggest problem remains education. I think ये सारा झूठ बोलते हैं कि जी 58% education हो गई है और फलां हो गया है. I think 10-15% से ज़्यादा इस मुल्क में education नहीं है. And the other thing is, honestly, in this country, unfortunately, women are maltreated and they have to produce children irrespective of anything, irrespective of their health, and nobody seems to be bothered about it. I think the whole nation needs to think about it, and particularly at the government level.
I want to make a comment.
Please go ahead.
Sir, ये देखने में आया ना कि जैसे we see the patients with carcinoma breast and we study, we have some researches on it. So, sir, family history in the patients of the carcinoma breast in our areas, it is not of that rate जो कि worldwide other studies हमें बताते हैं. At present in our areas, family history, the rate of family histories in these patients, it is only about 10 to 15%. और I think this is the reason कि अभी तक जो ये screening program है ये हमारे health care में अभी तक incorporate नहीं हुआ और कोई regular system नहीं है screening का फिलहाल हमारे पास. और ये है कि आने वाले वक्त में हम expect कर सकते हैं कि ये cases बढ़ें जिन लोगों की family history strong है carcinoma breast के लिए. तो with the rise in the cases in the families, हमारी गवर्नमेंट को भी स्क्रीनिंग प्रोग्राम को इनकॉर्पोरेट करना पड़ेगा एट टाइम्स कि स्क्रीनिंग प्रोग्राम के थ्रू ही हम अर्ली डिटेक्शन कर पाएंगे. और मे बी कि अभी तक इसकी इतनी ज़्यादा ज़रूरत नहीं महसूस हुई क्योंकि फैमिली हिस्ट्री के साथ पेशेंट्स बहुत कम है हमारे पास.
Okay, thank you. Dr. Samina Ijaz asked this question, why we have not implemented the genetic screening on the clinical level. I think Professor Majid and Dr. Frzana has already answered this question, and that should satisfy her. Any other question? If there are no more questions, I think we should move on. And Professor Salma Kundi is there. I don't see her. So in the end, I'll request Dr. Qasir Sajjad, Secretary General, Pakistan Medical Association Center, for his concluding remarks. Dr. Qasir Sajjad, are you there?
Yes, thank you very much, Dr. Qazi Wasit. Excellent, I would say, excellent presentation by both the presenters as well as the panelists. I think it's a very knowledgeable webinar today, and I must have a question, and I would like to ask a questions with the panelists as well as the speakers, and I have a comment also. Actually, Pakistan Medical Association, we have a very active worker, rather I can say, and the specialist. His name is Dr. Shah Sayyed. He, with his all team and the Pakistan Medical Association, is very much vocal and very aggressively, very extensively doing awareness as well as organizing these seminars and lectures on this today's topic, the breast cancer. The problem is that the people are, I agree with all the speakers. The problem is our scenario in Pakistan, that the people are not very much interested to learn or to follow the doctor's instructions, which causes the increase in the number of diseases, particularly the cases of breast cancer. पाकिस्तान मेडिकल एसोसिएशन ने बड़ी इंटरेस्टिंग बात मैं करना चाहता हूं कि पाकिस्तान मेडिकल एसोसिएशन ने with the help of the pharmaceutical company, one of the pharmaceutical company have established a a bus for a clinic of mammography. उसमें सारी चीजें थीं और वो बस हमारे पास पाकिस्तान मेडिकल एसोसिएशन कराची में खड़ी रहती थी। सुबह से शाम तक हमने एडवर्टाइज किया, लोग आए ये करें, लेकिन वी आर फेल टू अट्रैक्ट पीपल और लोग बहुत कम आए, नहीं कराया। फिर वी हैव डिसाइडेड टू सेंड दिस बस, दिस फैसिलिटीज टू देयर डोर स्टेप्स। हमने अपार्टमेंट में लोगों को भेजना शुरू किया बस को कि जी सुबह से शाम तक रहेंगे, लोग आए और अपने मेमोग्राफी कराएं और मोमोग्राम कराएं और डिटेक्ट कर रहे थे। जो अभी स्क्रीनिंग की बात हो रही थी उस पर मैं बात कर रहा हूँ। उसके बाद आर्ट्स काउंसिल ऑफ पाकिस्तान में चूंकि मेरी इन्वॉल्वमेंट है वहां पे, मैंने देखा कि वहां पे तकरीबन 10,000 मेंबर हैं। उसमें फीमेल्स आप समझ लें कम से कम 40-50% तो फीमेल्स होंगे या 30% एटलीस्ट। मैंने 3 दिन सुबह 10 बजे से शाम के 5 बजे तक ये जो फैसिलिटीज थी वहां मुहैया थी। डू यू बिलीव कि 3 दिन में कितने लोगों ने ये मेमोग्राफी कराई होगी वहां पे? आप में से कोई बता सकता है? एक अंदाजा लगाए, मैं आपको पता चल जाएगा इजीली कि हमारे यहाँ अवेयरनेस का, सिंसियरिटी का, सिंसियर होने का कि अपने उससे। और ये दिस इज इट वाज एब्सोल्युटली फ्री ऑफ कॉस्ट। कोई पैसे नहीं लिए जाते थे, उनको एक हार्ड कॉपी दी जाती थी, उनको एक सीडी दी जाती थी कि ये आपकी ये ओनली 9 लोगों ने
Sir, can I make a comment here?
सर मैं इस तरह कंप्लीट कर लूं फिर मैं सर उसको बोल सकता। और अगर आप इसी में बात करना चाहते तो बोल लें सर, प्लीज गो अहेड।
हाँ, मैं बता रहा था कि like in Lahore, this cancer care hospital has got quite a few mobile mammography units, and we send it to all the even remote areas. I think by now we have done few lakhs of mammographies, and then we sort of refer them to a hospital where free surgical intervention is carried out. And I think this has to be done at a much bigger level in this country, in every city, every province, because the disease remains undiagnosed in most of the cases. And talking of early breast cancer, I think about 2% of my patients in city of Lahore, which is so-called educated people, 2% of people might be having early breast cancer, but most of the times it's not uncommon to see getting breast cancers even today, unfortunately.
Yes, you are absolutely right, sir. मजीद साहब, एक्चुअली मैं सिर्फ इसको कंप्लीट कर लूं कि एट द एंड हुआ ये कि बहुत ही फ्यू नंबर से हम बहुत डिसहार्टेड हुए, एंड वी हैव donated with the consent of the pharmaceutical company to the शौकत खानम हॉस्पिटल कि जी उनका वहीं दे दें, वहीं सारा काम होता रहेगा। तो दिस इज वेरी अनफॉर्चुनेट, एंड व्हाट आई थिंक द पाकिस्तान मेडिकल एसोसिएशन have a view that we have to do a very extensive awareness program in every corner. The gynecologists, the surgeons, everybody, all the societies should do a very massive information to the public and tell public, लोगों को ये बताना होगा कि जी ये प्रॉब्लम हमारे इसमें हो रही है और इसमें ये these are the preventable diseases, इसको हम रोक सकते हैं, this is a preventable disease, इसको रोका जा सकता है और उसके रोकने के ये तरीके हैं। तो आई थिंक कि मैं समझता हूँ कि हमें सबकी जिम्मेदारी है कि हम कहीं ना कहीं, चाहे वो प्रिंट मीडिया हो, इलेक्ट्रॉनिक मीडिया हो, बजाय ये कि हम होटल में सेमिनार कर लेते हैं ब्रेस्ट कैंसर पे, वी हैव टू गो टू दी गर्ल्स स्कूल्स, गर्ल्स कॉलेजेस, यूनिवर्सिटीज, एवरी इंस्टीट्यूशंस, एजुकेशनल इंस्टीट्यूशंस, मैं समझता हूँ कि वहां पर ये जाकर हमें करना चाहिए। पीएमए इज डूइंग दिस, लेकिन हमें भी ज्यादा करना चाहिए ताकि इसको अवेयर किया जाए। मेरा एक सवाल है, मेरे जहन में आता है कि अभी आई थिंक मरियम साहिबा ने अपनी स्लाइड में दिखाया और दोनों सारे पैनलिस्ट ने ये बात पे एग्री किया है कि इसका जो कॉज है, इस कॉज में एक तो कंट्रासेप्टिव्स का इस्तेमाल एंड कम बच्चे की वजह से ये होता है। अगर कंट्रासेप्टिव ना इस्तेमाल किया जाए और ये जो बच्चे ज्यादा हो तो शायद आपने कहा है कि इसके रिस्क फैक्टर कम होता है, रिस्क कम होता है ब्रेस्ट कैंसर के। तो मेरा सवाल ये है कि हम तो यही कहते हैं कि जी आप बच्चे कम पैदा करें, उसके लिए कॉन्ट्रासेप्टिव्स की बात होती है। तो एक तरफ तो हम ये कह रहे हैं, दूसरी तरफ हम लोगों को प्रमोट भी कर रहे हैं कि जी आप कॉन्ट्रासेप्टिव यूज करें और बच्चे कम पैदा करें। मुझे जरा सा ये बात समझनी है, तो हम इसको किस तरह से, अगर किसी ने सवाल किया तो हम इसका क्या जवाब?
Yeah. Can I make a comment here?
Please
Number
go
one,
ahead.
that our electronic media can play a big role. I once suggested that there should be self-examination programs after midnight. You know, हम नरगिस के dances तो दिखाने में सारी family बैठ के देख सकती है, but when it comes to educating people, लोग कहते हैं जी हो ये तो बहुत बुरी बात है. That's number one. Number two, talking about Nali Para, yes. But would you believe in the Frzana Medical College, where you got the maximum number of females coming for treatment of cancer of the breast? On average, cancer of breast, women had 5 children. So I think we are at a loss in this country. You know that there are probably other factors which are in operation in addition to nulliparity. Yes, one can understand, but you know, I'm telling you, on average, 5 children per woman coming up with the cancer of breast in Fatma Medical College, Gangaram Hospital.
सर मैं इसके हवाले
I
से
think ladies might like to make a comment.
मैं मेरा सवाल का जवाब अगर
डॉक्टर
हो
काजी
जाए।
वासिफ है, मैं एक थोड़ा सा ऐड कर दूं कि मीडिया बहुत इम्पोर्टेंट पार्ट प्ले कर रहा है ऑलरेडी। पिंक रिबन और ये हम मैचेस में, क्राउड में, हर जगह हम देखते हैं। अवेयरनेस जो है वो काफी हद तक फैलाई जा रही है। हमारे जो कल्चरल मिथ्स हैं एंड द कल्चरल हेजिटेंसी है, उसकी वजह से those who had early lump or वो सामने नहीं आते, और दैट इज द रीजन के वो फिर एंड अप होता है सिवियर डिजीज के ऊपर। तो अवेयरनेस काफी हो रही है एंड डूइंग इट, ये बहुत करती रही है, एंड द पिंक रिबन पूरा वीक और मंथ सेलिब्रेट किए गए हैं, एंड पीपल आस्क कि ये पिंक रिबन है क्या, और then it is there. Yes, Faisal Sajjad, go ahead.
यस एक्चुअली मेरा ये सवाल अगर मिल जाए जवाब, अगर डॉक्टर मरियम और दूसरी प्रेजेंटर जो है कि ये
well, I have raised hand for the
Yes,
answer.
go ahead, sir. Professor Kiani.
Yeah, I mean, the answer to the question of Dr. Faisal is that yes, hormonal contraceptives increase the risk by increasing estrogen in the body. So there are studies, and studies have shown that if hormonal contraceptives are used and at the same time the woman is doing exercise as well, the risk is reduced. Then the risk of having hormonal contraceptives and CA breast, it can be reduced if physical activity is there.
What's the percentage of people who are practicing hormonal contraception in this country? हमारा तो सबसे बड़ा रोना ही इस मुल्क
सर रिपीट कर
में
लीजिए
ये
क्वेश्चन
है
प्लीज।
कि पॉपुलेशन कंट्रोल तो है ही कोई नहीं. I think you know, pardon me saying that, but with the passage of time, I think our population is going to. My question is that what's the percentage of people who are practicing hormonal contraception in this country? You know, क्योंकि हमारा population growth is in excess of 3%, which is highest probably in the world. So I think very few people practice that. So that factor may not be very much in operation in this country.
So can you hear me?
I would like your comments.
Yes, go ahead.
yes
Frzana.
Sir, I want to respond to Sir Cass's question. Sir, your first question was the association and the parity thing, and the second one was what is the our contraceptive prevalence rate. So unfortunately, you're very right that we are standing very low on even we have not met the desired need of contraception that we set the goals in MDGs and SDGs. It's still around 30 to 33%, and even after so many awareness programs and things like that in 2014-15, our CPR has reduced instead of going up. So you're very right that in our country, the number of users of contraception or oral contraceptive pills are very less. Again, in my presentation, I stressed upon this thing that studies in US and Australia have proven that the deaths due to reproductive health issues, deaths due to childbearing in whole world globally, they are almost double the deaths that are occurring due to breast cancer. So while we advocate um, stoppage of oral contraceptive pills to prevent breast cancer, we should keep in mind what what are our goals for population growth, what is our maternal mortality, and where do we stand for our need of contraceptive prevalence rate. So we always need to educate the women to have adequate birth spacing, as this is the requirement for good maternal health. This is what is advocated in our religion, and this is what we advocate as healthcare providers. So the important thing is that we can offer them alternate for birth spacing, as birth spacing is very important. While addressing a reduction in CA breast, we cannot ignore the maternal mortality of our region. So there is an association, as studies have proven, but with the advent of new oral contraceptive pills with very low doses of estrogens and with other contraceptive methods available, we should have a proper health education plan. And one thing, sir, I must say, as Sir Professor Majid was stressing upon it as well, and Professor Ziad, that we need to educate our healthcare professionals first. Because what I feel is that as healthcare professionals, we are ourselves very much confused. When we are confused, we're not clear. How can we educate mass population? And yes, Dr. Kaisa, your suggestion is very valid that we as healthcare professionals should focus on young age, on school, college, girls for awareness regarding breast examination, self breast examination, and when to seek for clinical breast examination if we really want to reduce the risk of breast cancer. Thank you very much.
Thank you very
Great.
much.
Thank you. Okay, Dr. Qaisar, your concluding
Yes,
remarks.
yes,
And,
thank you very much.
Dr. Frzana, Dr. Maryam, Dr. Ziad, and Professor Majid for their excellent interactive session.
Regarding
Dr.
the
Qaisar.
oral contraceptive pill, I want to make the comment.
Go ahead, please, very briefly.
Yes, sir. सर मरियम की बात को कंटिन्यू करते हुए सर देखें ओरल कॉन्ट्रासेप्टिव पिल्स बहुत ज्यादा उसका हमें रिस्क नहीं मिलता कार्सिनोमा ब्रेस्ट में, लेकिन जो उसका अगर कम भी है रिस्क तो भी रिस्क फैक्टर में और वो मॉडिफाइबल रिस्क फैक्टर में आ गया। अब अगर कोई और हमारे पास ओरल कॉन्ट्रासेप्टिव पिल्स के अलावा कोई दूसरे मेथड्स हैं कॉन्ट्रासेप्शन के, we should practice them. अगर एक ऐसी चीज जो रिस्क कर रही है कार्सिनोमा जैसे डिजीज के लिए जो कि लाइफ थ्रेटनिंग है, तो हमें दूसरे प्रैक्टिसेस की तरफ आ जाना चाहिए। There is not only a single option of contraception through the oral contraceptive pills. जो बाकी मेथड्स हैं उनकी प्रैक्टिस को प्रमोट किया जाए so that कि इस फैक्टर्स को अवॉइड किया जा सके। जब हमने उसको मॉडिफाइबल कह दिया तो हम मॉडिफाई कर सकते हैं ना उसको, तो हम मॉडिफाई करें इसको। दैट इज माय रिकमेंडेशन।
Okay, thank you. Dr. Qaisar Sajjad.
Right, thank you very much. I just say extremely thankful to our worthy presenters, Dr. Maryam, Dr. Frzana, and the panelists, Majid Chaudhary Saab, and everybody. I see Dr. Mulazim is also there, looking very smart.
कैसर सजाद मैं एंड पे अपने रिमार्क्स देता हूँ. अभी मैं फारिग हुआ मीटिंग में, वो मैं बिल्कुल आप लोगों के साथ रहा. माशाल्लाह काजी साहब ने बड़ी अच्छी प्रेजेंटेशन दी. कांग्रेचुलेशन टू फरजाना, साबिर, कांग्रेचुलेशन टू मरियम, एंड वेरी एक्सीलेंट प्रेजेंटेशन ऑफ द पैनलिस्ट. प्रोफेसर ज़ियाद कियानी, ये हमारे मुजफ्फराबाद की शान है, और हमारे उस्ताद भी इसमें शामिल रहे. तो आई थिंक कि पीएमए ने हमारी कमी महसूस नहीं होने दी. थैंक यू वेरी मच एंड आई इंजॉयड. मेरे कानों में लगा हुआ था वो मैं मीटिंग अटेंड कर रहा था, लेकिन मैं डॉक्टर फरजाना आपका लेक्चर और डॉक्टर मरियम आपका लेक्चर बड़े गौर से सुनता रहा. एक्सीलेंट एक्सीलेंट.
वेरी गुड. मुलाजिम साहब, आपकी कमी तो बिल्कुल महसूस होती रहेगी, क्योंकि ये सारा वेबिनार जो है पीएमए का, ये आपकी और हमारी जो ऑनरेबल प्रेसिडेंट हैं डॉक्टर सलमा कुंडी और काजी वासिक साहब की, और काजी वासिक साहब अगर नहीं होंगे तो ये वेबिनार तो होगा भी नहीं, क्योंकि सारी जो वो कहते हैं ना पीछे से बैकग्राउंड पे सारी अरेंजमेंट सारी करना. ऑफ कोर्स मुलाजिम साहब तो खैर उनके बगैर, तो यही मैं इनसे कह रहा हूँ कि आज हमने हमेशा मिस करते हैं और आज भी हमने आपको मिस किया. एंड I really thankful to all the participants also. I think we will again meet next Sunday with the another topic. So thank you very much, everybody.
Thank you very much. Thank you very much, Qazi Sahab. Thank you very much. Thank you very much, everybody.
Thank you.
बहुत शुक्रिया मुलाजिम साहब. ये तो मैं तो आपका प्रॉक्सी था आज.
काजी साहब बहुत शुक्रिया.
आप ही थे, मैं आपका प्रॉक्सी था. Thank you very much and thank you everybody. खुदा हाफिज. खुदा हाफिज.
Okay जी, thank you very much. खुदा हाफिज.
Thank you very much, Majid Chaudhary Sahab. Thank you very much, sir.